I'm trying to put it to the full screen. And this webinar on integrating age-friendly healthcare towards healthy aging for all is organized by the Task Force on HPH and Age-Friendly Healthcare. It was established in 2012 before the WHO publication of Aging and Health. And this task force is under the International Network of Health Promoting Hospitals and Health Services. This network was established by WHO to support their Healthy City initiative. It's about 30 years ago. Yeah. And can you see the slide? And is it moving? Now I move to the next slide because somehow
we can see them, Shruti.
You can see them. And did you see my picture now? It's the second. Okay, good.
Yeah,
Perfect.
Nothing full screen.
This is so important. Okay, so I'm the moderator of this webinar. I'm the chair of this task force, and actually, I'm also a former chair of governance board of this international network of HPH, and I'm the founding president previously of Taiwan's HPH network. And I'm still in the executive board of International Union for Health Promotion and Education, which is an official partner of WHO in the field of health promotion. And when I served in the government as the Director General of Health Promotion Administration, we started many works in this field, including this initiative. And seeing that Bogdan and Vania is one of the top outstanding person in their country, I have also to tell you that I'm the president of Taiwan's Association of the Top 10 Outstanding Young Women. Okay, I was elected when I was young. Now I'm old, so I have to serve the young outstanding women. So in this task force, we have a whole set of the age-friendly module, including an accreditation framework for age-friendly healthcare institutions, and we developed and we applied tools for clinical practice. Actually, we applied 4 M's and the ICOPE items developed by WHO, and we developed the indicators, and we have an organizational pathway for implementation, and we accredited all types of healthcare organizations and health services. So in Taiwan, currently, there are 1,160 health services accredited as age-friendly. We used to be the largest network in the world. However, then IHI has promoted age-friendly health system in the US and now expanding it to the other regions in the world. I know you have more than 4,000 health services joining your initiative. So now you are the biggest one. That is why we would like to collaborate with you. And so the purpose of this webinar is to support UN and WHO's action of Decade of Healthy Aging. The item 3 of their action is to promote older person-centered integrated care. So this is today's aim, but as we are part of the Healthy City Initiative, which is an ecological approach, we apply the system-based approach. So we actually emphasize very much management policy, teamwork, technology, and age-friendly environments, and collaboration with community partners. And this is today's program. So I will invite Oliver to say a few words, and Susan on behalf of Pedro to say a few words. And then we will have 4 presentations from the champions in this field. We will show you integration with community, integration with long-term care, between long-term care and hospitals, and integration with social services, and the WHO's framework for countries to do a better integration between healthcare and long-term care. And then we will wrap up. So then before I invite Oliver to say a few words, I have to tell you a little bit about something when he was young. Okay, Oliver now is the CEO of our international network and also vice chairman of the board at Optimedis AG, based in Germany. But when he was the technical officer of WHO Europe, actually he participated in so many things to launch and push the initiative on health promoting hospitals. So he was the co-editor of this quality management book on HPH and on the self-assessment manual of HPH. In Taiwan, every hospital used this one to do the self-assessment and improvement. So Oliver is one among the giants of HPH founders. Okay, so now Oliver, it's your floor. Thank you.
Thank you, Shruti. I feel like a superstar the way you introduced me. And it's fantastic because we've been collaborating for such a long time. So it's a real pleasure for me to be here with you today and to just share a couple of introductory remarks. I will keep it brief. You already introduced the HPH network, for which I'm also here representing as a CEO. It was founded more than 30 years ago by WHO, and it's still going strong. We have 30 countries participating and new networks joining. Actually, this year we've got a new national network joining. We've got 2 other national networks that are in formation. So it's not an idea that is losing speed, that actually it's an idea that is gaining more and more momentum to focus more and to emphasize more the role of health promotion in healthcare. And that's from many different perspectives. And I'm very glad that IHI is also represented here with Susan, because I've worked a lot in the quality and patient safety field as well. And even that field, if I say, is broadening up to recognize the contributions of health promotions to quality outcomes. So I think I'm very much looking forward to your reflections on that as well. Just a couple of brief remarks. I've got 5 brief points. First is the obvious. We have an aging population. We've got epidemiological transitions. People are getting older, and that's a good thing, but they need to get older in a healthy way. And the difference between living long and living long healthy is profound and has a lot of implications for the persons, for the families, and for the systems. And in order to look at healthy aging, we really need to make health promotion a much more integral role of healthcare provision, because healthcare services throughout the world are still focused too much on the acute period and do not consider sufficiently the contributions that other sectors, but also other parts of the healthcare system have to improving healthy aging. So I think that's a very important point that we are going to address today. The second point is, if we look at healthy aging and health outcomes, is really the one on disparities. The probabilities of living a long, healthy life are so different if you look at different social groups, depending on the social gradient, vulnerable groups, inequalities. And in many countries, we have differences in more than 10 years in life expectancy between the lowest and the highest social strata. And if you look at healthy life expectancy, the numbers are even higher. It might be 15 years, it might be even more if you look at regional level. So this is really not acceptable to have a 15-year differential in the probability of living a healthy life. The third point is really about the workforce itself. And this is different in different countries, but I can speak, for example, in many European countries, certainly in Germany, the health workforce itself is aging. We've got a lot of doctors and nurses that are over 60 already, that are looking or at approaching retirement age. And if we can maintain their health and maintain them 1 or 2 years longer in the system, doing their important work, this has really important implications for the sustainability of the system. So when we talk about healthy aging, I hope we will not only look at citizens and patients, but actually the workforce itself. It's a very important point. But looking at the workforce and the broad environment, we need to be aware that healthy aging also always has an effect on caregivers and societies as a whole. So it's not just a single person that is affected. Sometimes people need to take leave or unpaid leave to take care of older family members. That has an implication for the families, for productivities, for schooling, for a lot of factors. So it's not the patient, it's really a society that is affected by the issue of aging. And finally, the point about sustainability. Simply, it's a matter of fact in many countries with the demographic trends, we will not be able to maintain the social welfare systems in the same way if we are not able to address healthy aging and increase the number of people, the number of years lived in good health. So I think there are lots of very important reasons to look at this topic today, and I'm glad to have such high-level speakers here today with us. And thank you so much, Shruti, for convening this webinar. Back to you.
Thank you. And so then I would like to invite the representative from IHI to say a few words. Actually, Institute for Healthcare Improvement is a very, very important institute, not only in the US, but in the world, especially in the field of healthcare quality and patient safety. So we are very glad, in addition to their age-friendly health system development, actually, they have done so many works to improve people's health and welfare. So we couldn't be happier to have the representative from IHI. So Susan, the floor is yours. Thank you.
Oh, thank you so much. And I'm sorry I'm not quite as handsome as Pedro, and perhaps to not bring
nice.
the same lovely warmth to the table, because he is a joy to work with, and I know he's disappointed not to join you today. So it's an absolute pleasure to join you. I am becoming much closer in my role as Senior Director for Europe. I'm getting much closer to Age Friendly as we think in IHI about how we take the wonderful learning of the work that has been taken forward in the States, that has been so successful. And I'm not sure that our numbers are just as large as you are predicting there, but certainly more than 2,500 settings where Age Friendly is working, and more than 1.4 million people impacted by the 4 M's and that work in the States. And of course, in Europe, we're very excited to look at not only what is it about this intervention, this bundle of interventions that is so effective, and how people have been applying that in a range of settings, but also to think about the context in which you take that work. So I think it's very important as IHI thinks about our global reach and how we take our work forward when we have learned from one country and one type of cultural environment, how do we translate that to other environments that really works well for that system? And that is a big part of my role going forward, to help us think about how we do that for the Europe region, and think about the different contexts and the different ways in which we care for our elderly population in a variety of settings. Of course, IHI are huge believers in partnership and in networks. And I think that, to your point, Oliver, building the network is hugely important. We've learned such a lot from other colleagues who've done research around this. You may have heard of the Burgess Warwick Business School research, where they looked at the importance of networking in order to be impactful around their quality outcomes. It's fascinating work, and it looked at the overall success of organisations where the networks are very strong and add a huge amount of value to the ability to empower and create leadership for improvements in work. So partnership and networks, absolutely vital, and always looking for opportunities to facilitate that and also be involved in as many ways as we possibly can. But of course, all of our work is underpinned by using the method, the model for improvement, which is the way in which we learn, and the approach that we adopt in all of our subject matter and all of our approaches, whether that be acute care safety, as Oliver has previous experience of, as have I in my history as a nurse. and thinking about the rigorous application of a method to support implementation of good science and of good evidence-based practice. So you're all very familiar, I'm sure, with the 4 M's and what that work is, and the focus on creating strong, impactful practices around making sure that people have the support they need to function at a high level for as long as possible in their elderly years. And of course, we've developed over the period of, I think the last 3 or 4 years, have developed a lot of resources that are available, and we can send you links for all of those resources if they are helpful for others, to think about how you may want to consider this across the network and to support a variety of different settings. So I hope that was helpful to say hello and to join your group, and I'm really looking forward to hearing from the presenters today. So thank you so much.
Thank you, Susan, and we look forward to having more detailed introduction from IHI, from you or from Pedro regarding your works in this regard, and sharing your resources and evaluations about the outcome of those efforts is wonderful. Thank you for being here. So now I'm going to introduce our first speaker. He is Professor Liang-Gong Chen. His presentation is on developing a community for successful aging in place by and in an age-friendly hospital. We often say by and in because it's not only within the hospital's walls, but also in the community. We would like to work with them. Professor Chen is the director of Center for Healthy Longevity and Aging Sciences in National Yangming Jiaotong University, and he is now the superintendent of Taipei Municipal Guangdu Hospital in Taiwan. But in fact, he has been a champion in geriatrics, and we work together on many initiatives about healthy aging. And several years ago, when I was in the government, I worked with him to do a cluster randomized control trials in the communities to test the possibility of multi-domain interventions in improving physical frailty, depression, and cognition. And then he applied the evidence into his works. And then I'm going to share with you his presentation. He couldn't be here, but he gave us this video. Thank you.
Shruti, we can't hear.
Oh.
And we don't see video yet.
Not yet? Okay.
No,
So,
we still see the first slide.
Okay. Yeah, let me do it again. I'm just guessing whether it's okay. Yeah. So can you see the video now?
Now we can see it.
The voice?
The voice not yet.
Not good. The voice, the volume is low, right?
Yeah, there is no sound coming through yet.
No sound?
I think, Shruti, there's one tick box. If you cancel sharing and then when you click share again, there's a tick box at the bottom when you start sharing that says share with sound. And if you tick that box, it will allow us to, I think, just try it.
Where?
If you stop sharing your screen and then you start again.
Okay.
Perfect. And then as you're about to share, there should be a tick box at the bottom of the...
Oh, I see. Yeah, good.
There we go.
Thank you. Good. Haha. We have the expert here. Okay.
Hypertension, around 30% of diabetes, 40% of dyslipidemia, and almost 90% of the seniors has at least one chronic condition. and on average, they have more than 3 chronic conditions. Disease is one thing. The most important and most challenging condition is about function and their quality of life. So overall, in the seniors, there are about 1/6 of them have physical disability, about 5 to 10% people have dementia, and the self-perceived health among the older people are generally no good, or less than 50% of them perceive they're having good health. And their life satisfaction is also low, and they're feeling very stressful for their health condition. About 70% of them, they're worried about their general health condition. This makes the late life become a very challenging situation. So if you look at our lifespan, you can see that over the lifetime, there are about, in most developed countries, there are about 8 to 10 years living with disability that needing people to look after in your lifetime. And disregard of how old you live, I think the most challenging and currently the biggest consensus of the world is trying to compress the disability adjusted life years. So health is not just for all, it has to be for longer as well. So our goal is to reach the situation of the below errors, that no matter how older you can live in your late life, but we're hoping to compress the years of living with disabilities. So that is the meaning of healthy aging that proposed by the WHO. The WHO has proposed the structure of healthy aging since 2015, and there are several documents. And so since the year 2021, they together with the United Nations started the decade of healthy aging. So it is a global action to promote healthy aging. And there are several steps in the community to promote healthy aging. That is to enhance the intrinsic capacity and the functional ability. That's nothing to do particularly with disease. It's about function. So all those steps starts from screening to the community support and to the secure the referral pathway. So the whole strategic plan is very important for the community-based action plans to make the age-friendly health services happen in the community to every seniors. So to the perspective of the healthcare systems, it's a very huge paradigm shift that we have to, based on the literature from the WHO, we have to shift the healthcare system from disease to function, from treatment to prevention, from reaction to proaction. So this big challenge that needs, especially it needs to be implemented in the community. So that is the thing that we have to work on and spend a lot of effort on. So based on the structure of the WHO through the ICO, there are all the different stages of the prevention interventions are needed, such as the primary prevention, secondary prevention, even the tertiary prevention for the long-term care services. And all of them can be achieved by a community hospital. And besides, in the modern age of digital technology, WHO also endorsed the application of digital technology to help promoting healthy aging in all different settings. The hospital I'm working on, I'm currently chairing the community hospital in Taipei. It is not a very big one, but the major focus of the hospital is about senior care, long-term care, and community care. And in 2017, before the pandemic, The Economist has published an article saying that the future hospital should be like the control tower of the airport, that using a lot of digital technology, we can do a lot of outreach services in the communities, at homes, promoting hospital at home programs instead of making all the patients or all the seniors in need of health services into the hospital. That's before the pandemic, and that is even true after the pandemic. So we're hoping that we can really implement those ideas together with our previous evidences and technologies all together to promote healthy aging based on the needs of the community. So we have done a lot of trials before. So it's about the implementation for our previous trial results. The results include several settings. First, because older people may have multi-mobility, so they may have very fragmented care. They having multiple outpatient visits and different primary care physicians. So we have established the integrated outpatient services that has been shown to reduce the health costs by about a third per year, but improve the care quality by 50%. So integration is very important. The importance can be applied to the acute care unit as well. So for the integrated geriatric acute care unit in the hospital, we can see that through this integration, patient can be discharged with better physical function, and they also reduce the in-hospital mortality risk. Besides, because seniors, they usually need a lot more time and effort to recover to the baseline functional status. So the post-acute care is important. And we have proved that the effective post-acute care can reduce the one-year mortality risk by 62% and improve the functional recovery by nearly 50%. And in the community living older adults, we published a paper in Lancet Health and Longevity as the Taiwan model of health promotion programs in the community, which is called TIGER, Taiwan Integrated Geriatric Care Program. That overall, in combination with health promotion activity, that is multi-domain intervention, plus primary care physicians' involvement for geriatric syndromes and polypharmacies and all others together, that can overall improve the quality of life for the people living in the community with multiple comorbidity, together with reducing the dementia risk by 50%. And also in this paper, we've shown that it is highly compatible with the principles of value-based healthcare, which means it is of great value to the healthcare system reform. So now we're working on a hybrid evidence-based implementation research that is utilizing the previous trial results together with some new studies overall to promote the community level evidence to be generated through a very implementation approach. A good example is the tobacco smoking. That back in 2008, the Taiwan's tobacco smoking rate is about 21.9%, and the government used a lot of strategies and with the support of the evidence, all different kinds of evidence has been implemented, and in 2020 the smoking rate dropped to 13%. So that's the community level evidence. So we're hoping not just one trial, we're hoping to collect all those trials together to improve the community health. So we're thinking whether we can improve the intrinsic capacity of the community I'm working on from 2021 to 2023. So the whole structure will be making the Gandao Hospital as a control tower hospital. So we're going to promote a lot of more outreaching services and use a lot of digital technology and work together with other care providers in the community, and hoping to improve health for people at home, not only for rehabilitation, but also for health promotion, disease control, and some treatment of acute conditions. And all the data of those different services will be connected at the cloud. So before we do this, we have to figure out how many resources we have in the community. So in this district of Taipei City, eventually we do have a lot of resources at the community level, but most of them are more social services. So less of them are having strong scientific evidence supporting those health promotions. So that's the gap that we need to bridge for this program. And also, we implemented the integrated outpatient services at the hospital level. So overall, 5 specialties, 15 doctors are involved. We provide 25 sessions per week, and we've been over 20,000 of person visit has exposure to the integrated outpatient services with a high satisfaction rate. And we provide very effective post-acute care services. Back in 2020, there are over 160 patients being transferred from the tertiary center to our hospital. Over 90% of them, they obtained functional improvement, and very few of them are still needing home-based long-term care services, which means they regain their independence. And we're also the community level long-term care resource center. So we provide a lot of discharge plan, home health medical services, and others. Besides, we spend so much effort in the dementia-friendly community service network. So overall, we provide services for nearly 600 patients and about nearly 4,000 care consultations. And among them, 441 cases have been confirmed as having dementia. And we also have a community school for brain health. That's not a daycare center. It's more like a health promotion and resource center. And there are so many people attending the school and obtaining all their services, and from all kinds of services, from health promotion to avoid the financial fraud or other potential dangers in their later life with dementia. And we got a very good result as well. But in order to promote the TIGER program, as I just mentioned, we published in the Lancet program, it is a highly structured program. So we need a special occasion to promote all those, the whole set of multi-domain intervention. So we open our own academy at the community to promote the TIGER program. And we also affiliate with other existing programs with the community resources. So we provide all kinds of health promotion activities to the seniors based on the principles of our TIGER results. And there are so many people attending the TIGER program. And even during the pandemic, there are about 5,000 person attendance. They come to the program, and also over 3,000 person attendance. They come to the leisure activities. So it's not just exercise, cognitive training, but also having some leisure activities and some artistic or some personal pleasure in terms of their social well-being. And this is a result of the dementia-friendly integrated care network. Overall, we have been providing a lot of services for the community, people with potential dementia or cognitive impairment. But among the people with MCI, we can improve the MMSE score by 0.7, which is very good compared to other previous observational study. And we also reduce the burden of care for the family living with people with dementia. So it is also an important approach for the whole community. So prevention and reducing the care burden. And we do have strong digital technology support to promote precision healthy aging. So on the left-hand side is the smart hospital that we're running now. We have been spent a lot of effort, provide a lot of smart healthcare services. And on the right-hand side, we're also promoting the community to become a more smart community to integrate more smart devices or the algorithm, hardware and software, and making people more used to those services. And all together, those data will be connected in the cloud, even with the hospital data and the public health data together with personal health data, or even the lifestyle factors. And the cloud will be supported by our neighborhood high-tech company, which is ASUS. So they will help us to do the data center, and the analysis we're supported by the university, National Yang-Ming Jiao Tong University. So here is the new service we provided. We call it iHeart. I stands for intelligence, individualized, and innovative. HEART stands for Healthy Aging and Rejuvenation Platform, so that we can collect personal, community, and home-based data to the healthcare provider all together to generate a holistic approach for people to promote healthy aging. So this is the iHub.
There is no sound for this part. It's just the picture. I think that's all.
So this is all the work we're currently doing in the community at Gandao community, and hoping that all our residents to enjoy the healthy longevity and making the community more livable. It's a beautiful place that you can ever find on Earth. Thank you.
Thank you. Good. So that's the first presentation from Professor Chen, the role of community hospital. And next we are going to have the another example in Taiwan, which will showcase their integration with long-term care. And it is presented by Dr. Zheng Jie Wang. He is the director of the Integrated Long-Term Care Center and Family Medicine Department in Jiayi Christian Hospital, Taiwan. And he actually had a very strong background in primary health care. He worked in public health center and in local clinic. And in addition, actually, he took over the role of the former director, which is Professor Chen. Professor Chen actually now is promoted to be the superintendent of this hospital because of his great job in promoting healthy aging. And this hospital has supported the government to promote age-friendly healthcare accreditation beyond the hospitals to long-term care institutions and to primary health centers. So I think you are just like me are eager to listen to the presentation from another hospital example in Taiwan. And Director Wong has prepared a video, although actually he is here with us, and many of his colleagues are here with us, but he would like me to put the video to prevent any accident from the technology. So now I'm going to share again. Okay.
Hello.
Hi.
I also
Please,
provide a video because it's difficult for me to join everyone in English, so I provide a video.
No problem. I will put your video.
Thanks to moderator for the introduction. Ladies and gentlemen, I am Dr. Chen Jie Wen.
Do you hear the voice?
It's an honor to be here to share our experience in Taiwan.
Just the sound, no image.
Oh, no image. Oh. So let's start again. Share. And I click voice.
Thanks to honor to be here to share our experience in Taiwan.
Still no image. Maybe upload from
The number of people with disabilities in Taiwan
Let me
is
share it.
increasing at an average rate of
I think Shruti, what you could do maybe is if you open the video before you share, and then you only share the window with the video. So try instead of clicking on the video after you've shared your screen. So don't share your folder screen. Share directly the video. Try like that. It might work.
Okay. But then now I cannot see the video. Is it working now?
Could we upload the image here from our
Okay, yeah, you can do that. Yeah,
okay, we will try.
yeah, yes, good.
It's okay.
Thanks to moderator for the introduction. Ladies and gentlemen, I am Dr. Chen Wen. It's an honor to be here to share our experience in Taiwan.
Good.
The number of people with disabilities in Taiwan is increasing at an average rate of about 20,000 every year. In response to the resulting demand for long-term care, our government has implemented a 10-year long-term care plan in 2017, providing diverse and continuous services from home, community to residential care, which established a caring community to achieve the goal of aging in place. What is 10-year long-term care plan? It includes 5 aspects. 1. Personal and professional care. 2. Transportation to hospitals or rehabilitation clinics. 3. Assistive devices purchase and renting. 4. Respite care for family caregivers. 5. Home medical and hospice care. Our Chai Christine Hospital was established in 1958. It currently has over than 1,000 beds and over than 3,000 employees. There are more than 10% of our employees working in the community-based integrated care system, and we allocate an annual budget of $10 million in this field. We are taking care of around 4,700 elders currently. Our home medical team provides integrated and multi-specialty care, including family physician, geriatric medicine physician, neurologist, cardiologist, and nephrologist. Our long-term care service include dementia care spots, daycare centers, caregiver centers, long-term home care centers, and the long-term care facility. About our team cooperation. If the elders needed home medical care after discharge from our hospital, the community home care nurse will come to the ward in advance for understanding the clinical condition of the elders, and then arrange doctor home visit within 1 week of discharge. Due to policy factors, most home medical care are not provided by the same teams as long-term care service. In practice, when the doctors visit the elderly at home, they could only obtain fragments of information related to the elderly through the notes written down by the home care worker. Co-visit. In order to eliminate this issue, in Chai Christine Hospital, we have integrated home medical care and long-term care service within our system. Our doctors and home care workers jointly visit the elderly every 1 to 2 months. It is especially important when the family support system is weak or there is a lack of caregiving knowledge. Through this, we can better understand the current situation of the elderly and then develop a comprehensive treatment and care plan, which may reduce the chances that the elderly need to be sent to the hospital. In usual days, our doctor and home care workers discuss the elderly's health issues through video calls or online groups we call Line App when necessary. Our community hospice network. We assist community hospitals, local clinics, and nursing homes in providing hospice care because they might be lack of relevant experience. Our nurses go with them to visit the elderly and provide them guidance in the process. And we also conduct relevant continuing education courses. In the end, the actual participation rate in hospice care is very high, near 100%. And death in place of residence rate is 81%. Besides, more elders who required hospice care were identified from the community. The proportion of community network referrals increased every year. About physical environment modification, our physical therapist could visit the elderly's home to evaluate the environment before the elderly discharge. Our service includes installing the handrails, elevating the height of toilet seat, providing electric bed, wheelchair, empathy chair, and so on. Since the project has started, the for-instance rate within 2 weeks after discharge is 0%. Talking about innovative technology applied in long-term care. By using a smart bracelet to detect the sleep conditions of the elderly, we could adjust the dosage of sleeping pills based on data and clinical status. We use portable wireless ultrasound to assist in diagnosis and treatment in home medical care. Furthermore, by placing the transmitter on elderly with dementia, we can track their footsteps in Tri-City through the app to prevent them from getting lost. Telemedicine in rural area. Because it is very inconvenient for the elderly to seek medical treatment, our doctor will approach them and use equipment to transmit the images back to our hospital. With the accelerating trend of aging, efforts are still needed in many fields, such as telemedicine and the hospital at home. Therefore, relevant policies will be implemented in 2024. We will continue to create a better long-term care environment and strategy. Thank you for your listening.
Thank you.
Thank you, everyone.
Thank you. Yeah. Thank you for the very explicit and clear presentation. I just received many messages from the Taiwanese colleagues saying that they couldn't access at 8 p.m. Yeah, so probably many. We are sorry about that, but I've tried to notify them to access again. So thank you. And next, we will move to Dr. Bogdan Chiva-Jurka. Sorry, I couldn't pronounce your name correctly.
That's perfect.
Thank you. He is the global lead and clinical lead in the National Academy for Social Prescribing UK, and he is the honorary lecturer of the University College London. And he was named as the top 100 most influential people in health in the UK in 2022. He has contributed a lot to the development of social prescribing, and he continued to promote it to many different countries. And today he is going to share us on the topic of addressing social needs in caring for older patients, the experiences in social prescribing. We are very happy to have you. The floor is yours, Bogdan.
Thank you very much, and my pleasure entirely. And I'm truly honored because I'm surrounded by amazing leaders in the field. And there's not much more to say for me in the background, because I was just about to zoom out a bit and tell you a bit about the issues that we're facing. But I think Oliver spoke really nicely just earlier about disparities. And as you all will be familiar with the work of Sir Michael Marmot on social determinants of health in England, in London alone, he did a study where he showed that if you move from the central Oxford Circus station, which is the most central point, as you move one station away from that underground station, you lose 1 year of life expectancy. So by the time you reach 20 stations away from the center of London, you would have lost 20 years of life expectancy. And that's within the same city. We're not talking about different countries. In the same city, in the same country, you have a 20-year life expectancy difference based on where you were born. So we know the impact of social determinants of health has a crucial role. And I have the joy of having a clinical background. I work in emergency medicine. I'm an emergency medicine doctor by background. And I'm not sure if that's good or bad, because I think sometimes we as clinicians, we are to be blamed for some of the problems that we cause. And here's some of the problems that I'll start you off with. In fact, in England alone, research tells us that 1 in 5 appointments, so 20% of all the people that we see in hospital come for pure social reasons. And these will include loneliness and isolation mainly. They would also include financial debt or housing issues. But 20% of the people I would see in the emergency department every day come for social reasons. And that's highly concerning. The next point is actually what I've seen this week when I was in emergency department, which is the fact that 25% of all the admissions to the emergency department in England are for medication side effects. And it's a bit of a vicious circle because we have the elderly, especially who come in with low mood. They may have lost a relative, they have no friends, no family, and they have no one at home, and they would come with low mood. And because we, the clinicians, may be so busy, we will only be able to perhaps prescribe an antidepressant instead of trying to look beyond and dig deep at the root cause of the issue to understand what truly matters to the individual. So we are in this, as Prof. Chen, I think earlier described it, reaction rather than proaction. And this sick care model that we've propagated and cultivated over the years is something that we must change. And certainly I see this revolving door every single time in the emergency department. It's one in, one out. I stick a plaster, and sadly, I send somebody back home to what made them sick in the first place. So I'm shooting myself in the foot, really, because I will have to see them again in 2 weeks' time, probably. And the other statistics lately from England are that, as was shared earlier, 6 out of 10 people have at least one chronic condition, and we're talking here about all ages, and 4 out of 10 would have 2 or more chronic conditions. And I wish I could tell you England's healthcare system is all sorted, but sadly, as you would have seen on TV, the doctors are striking. We have huge pressures on our healthcare system at the moment. So this sick care model doesn't work anymore. And I think what's happened over time, we've confused the word health with healthcare. We've institutionalized the delivery of health. We've placed ourselves in hospitals with white coats, and we've been telling people what to do, and without realizing that, in fact, we are not walking the talk. We are not preaching what we should do in terms of the WHO definition, which was in 1948 saying it's not the mere absence of disease that health means, but it's rather the whole social, psychological environment around us too. And we're in 2023, and sadly, we still haven't done that. But our government in 2019, I was involved together with other colleagues in producing a solution, an innovative solution that's existed for many years, but at pilot level, called social prescribing. In 2019, the government tried, like many governments around the world, to look at the future of healthcare in England and try to focus a bit more on population health. And there's a few keywords that are flagged in here, namely boosting out of hospital care, making sure that we redesign the services to reduce the pressure on emergency and hospital services, and a wider personalized care approach. So focusing on what truly matters to people as opposed to our presuppositions of what we think matters to them through shared decision making. And we came up with a model called social prescribing. And you can read further in the WHO toolkit that colleagues from the Western Pacific region have put together, and we've supported this. But this picture really describes what social prescribing is. And it's very simple. I'm going to try and annotate a bit as we go on the slide. But if you imagine a lady that presents to the doctors, let's call her Sarah. If Sarah comes to me as the clinician with, let's say, low mood, in this case, I will be able to look for any medical causes that Sarah may have to her headache or low mood. And then from there, I will be able, within the time I have available, to refer Sarah, if she doesn't have a biomedical problem, to someone that we've created called a social prescribing link worker. And that's the person in the middle here. A social prescribing link worker is a completely new role that we introduced in England in 2019. It's similar to a nurse, a midwife, a pharmacist. It's a completely new healthcare professional that was added into the system. And this individual, this is where the magic really happens, because this individual gives people something I would never have available anymore in today's day and age. It's the most valuable resource of today's day and age, which is time. And they have the time to sit down with the person to understand what truly matters to them. And in fact, they have 1 hour for each patient. I, as a doctor, have 10 minutes in England. I'm not sure how much time colleagues have across the world, but in primary care and in the emergency department, you don't have the luxury of much more time than that. But the link worker is able to sit down, and what they do, they are training motivational interviewing, healthcare coaching, and they're able to co-design and co-create an intervention. And then they have a menu of activities. imagine going to a restaurant and you have a menu of everything that's happening in your local community. And based on the preferences of the patient, they are then able to refer them to services in the local community. Now, the most important element here comes back to disparities. We believe social prescribing works best for those most affected by social determinants of health and from poor to poorest boroughs. The reason I'm saying this is because when we think about social prescribing, you may be thinking patients get referred to art, music, gardening. That's true. But actually, the majority of the patients that we see are individuals who would never liaise with the clinicians, would never do what the clinicians say. So we would have a big struggle in collaborating and co-creating this intervention with the patient as clinicians because of the time barriers. So what we see quite often is people impacted by financial worries who come in because they're stressed, with low mood, with headaches, but actually they don't know the language, they don't know how to apply to benefits. And in this case, the link worker is able to build the trust over time and able to handhold them through the process of what they can apply to. And then they can also walk them to the physical activity class. They can go with them and they will make sure that they follow through in the community. So it's very different than the doctor telling someone directly to go exercise or go gardening. We think that's signposting, and it's something doctors have done for a long, long time, but sadly that doesn't work, as we know, especially with certain demographics in some cases as well. Now, one thing for you to remember is that in England, this middle part, this link worker, has been funded by the government fully. £300 million of investment have gone into that, and we've launched that in 2019, and we are now 4 years down the line. And this is a busy slide, but just a graphical representation to say that we've started with a few pilots. We had a few link workers in the beginning. The pandemic, in a way, acted as a great boost because there were many people lonely and isolated at home. So we really could help them to stay in touch with the outer world and with online and community activities through the social prescribers. And I'm really pleased to say that the things that you should focus on is that as of this year, England has reached 3,700 social prescribing link workers, which gives us at least one link worker for each primary care clinic. So every single patient that would visit their general practitioner in England would be able to access social prescribing through that as well. And the government has continued their support, and they've just announced that they will triple the numbers of social prescribing link workers in England to 9,000 in total. And we've started including it in various Department of Health pathways for dementia, musculoskeletal conditions, and diabetes and cardiovascular conditions as well. So it's moving on. But does it really work? Well, there's a study recently, and this is good for the politicians who always want the numbers, but there's a good study from the London School of Economics that showed that social prescribing in England per year saves 4.5 million appointments with doctors that don't have to take place anymore. And that's just in primary care. The equivalent return on investment of that is £300 million, which covers the cost of the whole program and leaves some money back for reinvestment into the system as well. And it's not only primary care appointments that are being saved, but on PubMed and other databases, you will find various studies that have quantified the decrease and reduction in emergency department admissions, anywhere between 20 to 40% reduction in any attendances from those individuals who've been referred to social prescribing. And for anyone who's an evidence geek out there who wants to read more about the evidence, we at the National Academy of Social Prescribing are Department of Health funded. We work with the government in England, and we work also with the WHO to forward the case for social prescribing. And we've built this academic collaborative network, and we have evidence on the various fields of social prescribing. And you can read more on this link over here. We have a wide network, and Taiwan is actually part of it. This is an old slide. I haven't updated it, but many Taiwanese doctors and professors are working to advance this in Taiwan as well. And so we will add and adapt this map to make sure, Shuti, that everybody in Taiwan is also on the map. But we're working with 32 countries in the WHO to make sure that we advance the agenda around social prescribing. And one size does not fit all. So what works in England may not work in other countries. And in fact, we've seen some other countries have decided not to create a completely new role. They've just decided maybe to use the social worker who had capacity to do those things to do what the link worker does. For us in England, we needed a new role because our constraints on the healthcare system were already too high. But other countries could use different models as well. And they take different names, the social prescribers around the world. In Japan, you might be familiar with the Sheikatsu Shian concept, who are based in the community and do very similar things to the social prescribers as well. You have the community connectors in Australia and the well-being coordinators in Singapore. But many variations around the world, and in particular, our Singaporean colleagues have started doing social prescribing from secondary care directly rather than from primary care as we did in England. So many variations in there. And for those of you who would be interested to seeing more, the WHO report that we created with a map of the globe includes a compendium of case studies of all the countries who are doing social prescribing currently. There's 25 countries involved, and you have a glimpse of their policy context, how the healthcare system works, and some examples of how social prescribing works. And you're welcome to have a read of this document later as well. But I know I'm short on time, so I'll leave you with one final thought. Usually, this is what we think health looks like. And sadly, we think about doctors, nurses, pills, procedures. But actually, this is a more accurate picture of what our healthcare system currently looks like in England. Hospitals, quite frankly, are for repairs. And we know for sure that health is actually made at home and within our local communities. Thank you very much. And I hope this was helpful. And I'm glad to meet so many enthusiastic colleagues from abroad. And I look forward to connecting with you all soon as well. Oh, I think you're on mute, Shruti.
Well, thank you. Thank you, Bogdan. It's amazing. And Sir Michael Marmot has been advocating for health professionals' role to support the initiative in reducing the gap. I think that's wonderful to see the social needs and to do something about it. It's good for the patient and for many other things. Wonderful. And I think the name elsewhere, well-being coach or well-being coordinator, is very positive. Thank you. So now I'm moving to our last but not the least speaker, Dr. Vania de la Fuente, another very difficult name for me, but again, also a very outstanding young expert. She will introduce WHO's framework for countries to achieve an integrated continuum of long-term care. Vania is an independent senior consultant in healthy aging. She is a former WHO technical officer in the unit of demographic change and healthy aging, and she's another top 100 outstanding person. She is the candidate of the top 100 women leaders in Spain, and she participated in many healthy aging publications by WHO, especially, for example, this global report on ageism published in 2021. We are very happy to have Vania with us. So now I give the floor to Vania. Thank you.
Thank you so much, Shruti. Can you all hear me well?
Yes.
Yes, it's really hard actually to come after such great speakers before. And I was just listening to you also, Bogdan, and I guess it really spoke to me what you were saying at the beginning, because I am a medical doctor by background, but then I actually also pursued a degree in social and cultural anthropology because I was missing all of those elements that influence our health that are just not seen in clinical practice. I just thought it was a very narrow view of health, and I really wanted to understand, what else is making people come into the clinic in the first place, and what can be done at the community level to avoid that from happening. So again, your presentation really spoke to, I guess, my professional career as well, and the steps that I've taken. Today, I will be speaking to you, as Shruti was mentioning, about long-term care and specifics, the long-term care framework that has been proposed by the World Health Organization. So again, here we will be looking at the type of system that is required for those older people who have significant declines of intrinsic capacity and who therefore require the assistance of other people to be able to carry daily activities such as eating, getting out of bed, getting dressed, or cooking. But before I present this framework, I really wanted to start by giving you by presenting the reasons why we actually need these long-term care systems in the world. And the most fundamental reason, I would say, as to why we need these systems is that they can enable older people who have these significant losses of capacity, as I was saying, to live with dignity and to have their human rights fulfilled, even when they experience these losses. But there are also two other reasons why I think we need these long-term care systems, which I present on this slide. The first one is that 2 out of 3 people are likely to need care and support from others to perform these activities at some point. So globally, it's estimated that around 142 million older people are unable to meet their basic needs independently. And we also have to consider that access to long-term care services can help delay and slow down the loss of intrinsic capacity, which can allow people to live independently for longer. So I think these reasons should really help us think as to why we need more efforts to develop the long-term care systems that are unfortunately lacking in many places around the world. Long-term care systems can also help reduce inappropriate use of acute healthcare service. We were hearing about this from other presenters today, which can, again, help families avoid catastrophic expenditures. And we also need long-term care systems because relying on unpaid informal care is just not sustainable. We know in Europe, so estimates in Europe show us that informal care accounts for as much as 80% of all of the long-term care that is provided nowadays. But we also know that with women taking on more roles in the workforce, this is just not going to be sustained in the long run. We also see that family structures are changing. People are having less and less kids, which means that, for example, by the time that I may potentially require long-term care, I may not have a child of mine who may be able to care for me. So it's time, I think, for governments to start taking on this role so that they can provide the care that we need in different points in time in our life. We also know that most caregivers are women. And obviously, when this responsibility of care falls on women, we are likely to then perpetuate gender inequalities. And we see that most caregivers are women, not only in the informal sector, but also in the formal healthcare workforce. In Europe, just to give you an idea, women represent close to 2/3 of informal caregivers, and women also outnumber men almost 9-to-1 in the formal long-term care workforce. Another important reason why we need long-term care systems is that there is a great need to have them precisely where they're mostly lacking, which increases obviously suffering, reduces quality of life, and it places extra burden on caregivers. As you see here, so available data suggests that there is a higher prevalence of care dependence in low and middle-income countries, and we know that by the year 2050, 80% of all older people will live precisely in these settings where there are currently no systems for long-term care available. But this is not just an issue, and I really want to emphasize that, of low-income countries. It's also an issue in high-income countries where the readiness of these long-term care systems is also quite limited. And I think we've all really seen this in the context of the COVID-19 pandemic and the horrors that we've seen happen in long-term care institutions in many countries. And as you can see in this graph, just half of people with limitations living at home do not receive sufficient long-term care in OECD countries. So these are all high-income countries. And again, it speaks to the point that I was just mentioning, that also high-income settings are not ready to provide the long-term care that older people require. And it's important to emphasize also that most older people in need of long-term care will wish to remain in their homes as long as possible. But despite this preference, as you see the number on the slide here, the proportion of long-term care recipients who received care in their home rose only marginally from 67% to 68% between 2009 and 2019. In 10 years, that's only a rise of 1%. And again, it's not like older people and their families and their caregivers have not been mentioning this preference. And now, as I start introducing the long-term care framework that is presented by the World Health Organization, I just wanted to say that obviously WHO's work on long-term care, it's driven by the UN Decade of Healthy Aging that, for those of you who don't know, this started in the year 2021, and it will go on until the year 2030. And as you see on this slide, the UN Decade of Healthy Aging focuses on 4 key action areas. And the last of those action areas, as you see here, is precisely providing older people who need it with access to long-term care. So all of the work that WHO does in this space falls under that action area. And there are several actions that the WHO Secretariat with other UN agencies has committed to as part of this, this action area to provide long-term care. And the first bullet point, which I have highlighted here, is the one that focuses on providing this technical support that is required to support the development of national situation analysis to enable countries to understand where they are in the provision of these types of systems that are required and the actions that are needed. And this is where the long-term care framework falls under. So as you see here, this is a tool to help assess country readiness for the implementation of long-term care services. And it aims to guide countries in assessing system-level components to implement sustainable and equitable long-term care actions. By applying the framework, countries can begin to develop and shape their long-term care system, basically. And it's intended to be used, as you see, by governments, both national and subnational. And then many of the actions are also, I would say, relevant for other stakeholders at the country level. This can include non-governmental organizations that are also pushing to get long-term care systems in place. It can be the private sector, healthcare providers, and development partners. And those in academic institutions may also find it helpful in identifying areas that require more research, which are quite a few. The long-term care framework, it considers that, you know, a series of principles that need to be met. And those are the ones that I have included here. And they're all equally important. The first one is, and I have already, I guess, mentioned this earlier. The first one is that governments need to be the ones taking overall responsibility for the stewardship of the long-term care system. We cannot keep relying on informal care because it's not sustainable, because it doesn't provide, I guess, the means for adequate training and to be able to respect, as I was mentioning, the human rights and dignity of older people who require this type of care. Secondly, it's very important that the long-term care system is affordable, that it's accessible and equitable. It must build on existing health and social care systems. You don't need to build something anew, but you need to consider what you have there and make it work and make it coordinate. Because again, we've heard about the problems of fragmentation within healthcare, but we also have fragmentation between health and social care. And when this happens, the burden is on the person who's requiring that care, who is then unlikely to be able to navigate the system to receive the type of care, both in health and in social, that they need. In countries with more developed health systems, this may mean that long-term care can make use of the existing health system infrastructure as a basis. And in countries where there is more limited health systems, the focus could be on mainstreaming long-term care into primary healthcare provision as part of a wider reorientation of primary healthcare to primary healthcare. The third principle of the long-term care framework is that the system must uphold the human rights of older persons and their caregivers. This means that the older person really needs to be placed at the center of care. And last but not least, it must be, again, oriented around the person and the needs that they share, and it needs to be provided, as I was mentioning, that non-fragmented way in a continuum with other services. So we have that the overall outcome of the long-term care system and also the principles that I just presented. And this is what the continuum of long-term care really looks like. But what I wanted to draw your attention to is the 6 elements of the framework, which you see here. And these are the 6 elements that will need to be evaluated and that are required to achieve an integrated continuum of long-term care and to facilitate, obviously, the integration of long-term care services with existing health and social care systems. We're talking here about governance, we're talking about sustainable financing, we're talking about having the information monitoring and evaluation systems in place. the workforce that is required to deliver long-term care, service delivery, and innovation and research. I won't have time to go into all of those, but I just wanted to give you an example of one and the types of things that the framework looks at and the vision that it proposes for countries when they're evaluating their readiness. So I will be focusing just on the workforce. And here are some typical problems that we find across countries when looking at their long-term care systems is that there are not enough formally trained and paid care workers to provide the long-term care to older people who need it, right? Most care, as I was mentioning, depends on unpaid carers. These are normally women who are family members or volunteers, but they don't necessarily have any formal training to be able to deliver good quality care. Also, many unpaid carers, and this often goes unnoticed, but many unpaid carers are actually older people themselves who also may have long-term care needs or other healthcare needs and may be facing poor working conditions, precarious employment, or even poverty because they may have to forego employment opportunities to be able to provide this care. And also family carers are often overburdened, which can lead to burnout and eventually inadequate care. The vision here is that unpaid carers and paid care providers receive adequate training, that the training is coordinated and provides that integrated continuum of care, and that they receive support and decent compensation and career opportunities to maintain an adequate skilled workforce. For each of these 6 elements that I was just mentioning, including workforce, the thing that the framework allows you to do is to detect where you are as a country. So it uses a traffic light system, as you see here, to indicate whether a specific action is not available, whether it's partially functional or fully functional. So again, this checklist is meant to help countries assess where they are, identify those potential gaps, and then plan for next steps to be able to then move towards the development of that sustainable and equitable long-term care system. This is an example of the checklist that is used, for example, for the element of governance. So you see here that there are several questions that will be asked of the country, and then they can just add in the rating. And the checklist is just meant to, again, guide countries to determine where they are and see the actions that are still required for them to have a fully functional long-term care system. It also allows them for adaptation to national and local context, and this should be done, of course. And the idea is that it's not just used once, but that it's used by countries periodically to monitor the progress that they've made for this country preparedness. I will be providing the link to this framework in the chat for those of you who are interested to learn more. And I'm afraid I can't give you more information, but obviously we had the 15 minutes, and I do hope that I've convinced you of the need to develop long-term care systems across the world, and that you've learned a little bit about the framework that the WHO is proposing. I thank you all for your attention and look forward to answering any questions that may have come up. Thanks.
Thank you, Vania. I think the checklist and the traffic light system is quite helpful. But actually, when Oliver developed the self-assessment tool for hospitals, it's also, I think it's also the 3-scale design. But then most of our hospitals chose the yellow light, the partial. so then eventually in Taiwan we split it to 5 scales. So the lowest one is less than 10%. The highest one is more than 90%. And then we have the around 25%, around 50%, and around 65%. So that those who have done most of the way, more than half the way, can see their own progresses. Yeah, wonderful. Thank you. So now, although the time is late, but still, I think we would welcome 3 questions. So is there any question or comment from the panelists or from the audience? And there is one question in the Q&A board. It's Karen. Karen asked about climate change, whether this is something we are doing for older persons, when there is extreme weather, what do we do to support them? I wonder whether Dr. Wong, would you like to answer? I can answer part of this. In fact, the government has a warning system. So for when it's very hot, or when it's very cold, or when the air pollution is to the purple degree, then the government will send out a warning, and then the Health Promotion Administration will have the press release to warn people. But of course, you might say this is not enough. So some people here in Taiwan also are saying that can hospitals and clinics have some connection with their patients, and to send them warnings about the extreme weather or the high degree of pollution, and tell them what to do. Although the government is we always release to the press to say, oh, you better stay at home, those things, especially those with respiratory disease or cardiovascular disease, etc. Yeah. Is there anything more we can do, Dr. Wong? Do you have this kind of activities? 翁主任他这个刚刚在那个问答 let me translate in Mandarin， 刚刚在那个问答那边有问说，哎，那如果是有极端气候啊，有这个有没有对这些老人有什么样的警示系统？那我刚刚是说政府是有一套标准作业，但是我们那时候有在想说，医院能不能也有一些对你们的病人的警示系统？但是这个其实，除非你们平常就跟这些病人就是有一套那个资讯上联系嘛，哈，不然是不容易。你们有没有在临床的部分，在这个部分说今天比如说那个紫爆啊，哈，这个空污比较严重的时候或怎么样，你们会去做什么？特别做什么吗？如果没有也没关系，因为我相信其实这个是不容易，对。
目前是在 ESG 的一个部分哦，那我们目前其实才刚开始，那目前也是针对空污的部分跟那个高温高湿度的部分会做一些警示这样。对，在社区的部分，对，那社区跟员工都是我们会提供警示的部分，但是目前也仅限于空污还是为主的。对，那至于极端的高温，
社区会做什么？会给病人什么样的讯息吗？会传简讯或干嘛吗？
我们去办讲座，
在社区
讲座 ，OK，
提升他们的职能，就是关于
OK，
有哪些可以取得资讯的地方。
Okay, let me translate.
Okay,
Listen, because our hospitals are doing the ESG, environment, society, and governance, and regarding their stakeholders and the environment, they provided education and awareness raising activities in the communities, but still difficult. I think unless we have those very well developed connections, digital connections with our patients. Otherwise, it's difficult to do individual-based warming. Yeah. Okay. Any other question? So Maria posted a link here about the long-term care framework. Yeah. So anyone who is interested might access the link to download the document. And yeah, aging workforce. Yeah, indeed. And as Oliver mentioned, we need to become age-friendly workforce. And actually, health promoting workforce is part of the 4 dimensions in health promoting hospitals. Yeah, so that's very important. So
okay,
if
there's a question in the chat about social prescribing, Shruti.
Oh yes. Let me see.
How the social prescribing worked when you met the COVID-19 pandemic.
Oh yes, yeah.
It's a great question. I can comment on that. It's fascinating because we believe it's really helped us solidify the support, because there were many individuals who were stuck indoors and at home, lonely and isolated without connection. And it really provided us an opportunity for at-home interventions. And we developed many virtual wards as well for anyone interested in this idea of tech, especially for what Dr. Cheng mentioned earlier as well. And we do have a lot of technological support at home. There's a program in NHS England called NHS at Home. If you Google that, you'll get a lot of information on how we support with virtual wards. But specifically, the social prescribing link workers provided a lot of connectivity support for individuals who are stuck indoors. What was a barrier, as you can imagine, was IT and digital infrastructure. So we did notice there were certain demographics that were supported more than other. So it comes back once again to health inequalities and social determinants of health. And somebody mentioned in the chat that, you know, we shouldn't leave anyone behind. And that's certainly something that we try doing now. And that's why all of our efforts are done in a value-based care. We're trying to support those who need it most first, and then move on to the rest. It's fascinating when you look at the referral pathway, because we allowed also self-referral for social prescribing. And what's fascinating is that when you look at who self-refers, it's of course those who are middle-aged, white British, the dominant group of that country. And they would ask you because they know that dancing or sport or physical activity or gardening is good for them. Whereas the people you really want to reach quite often come to us directly in the hospital when they are already very unwell in the greater hour of need. And that's the point where you can catch them and say, okay, it sounds like you have a medical problem, but it also looks like there's something more happening in your life. And from there, you can move on, which is why we base social prescribing in the healthcare system rather than basing it in the community. We noticed that community attracted quite a lot of people who had a lot of support, whereas healthcare, whether they liked it or not, a lot of people would just end up with their doctor in their greater hour of need. So just very interesting when you look at the data.
Yeah, indeed. Thank you. And also on the chat board, Annie has answered the previous question that for living alone older persons, we did have the system to reach out to them by telephone to notify them one by one when there is extreme weather or very dangerous pollution. And many hospitals and clinics have developed social media groups with their patients so they can send out messages through the groups. Okay, so thank you so much. Wonderful webinar, wonderful panelists. And also we are very glad that Oliver can stay with us, and also with Hannah from IHI, Susan from IHI. Thank you so much. It's very late, especially in Taiwan. We have many colleagues worldwide from different countries, and also a lot from Taiwan and a lot from Jai Christian Hospital. Thank you for your great work, and thank you for staying so late. Go to sleep quickly, and because I know you are going to have a very hard working day tomorrow. So thank you, everyone. It's great to have you, and we will arrange the next webinar soon, according to those topics you are interested in. Okay, so thank you all, and bye-bye. Bye-bye.
Bye, everyone.
Bye-bye,
Thank you,
everyone.
好，拜拜，拜拜。
And bye.